seminar series. And today we're extremely delighted to have Bob White, who is an instructor in anesthesiology in our Department of Anesthesiology. And he is one of the past recipients of the Dean's Diversity Award. Well, you were a fellow, is that right, Bob?
Yes, when I was a fellow.
Okay, great. So he'll be speaking to us today about disparities in maternal care. Thank you very much.
Thank you for that introduction. Hi, hello everybody, I'm Robert White. I'm one of the obstetrical anesthesiologists at Cornell. I'm also a disparities researcher. I have a master's degree in clinical research methods, which gives me some knowledge or insight into the methodological issues with studying disparities. And today I would like to focus in on identification of racial ethnic disparities in maternal morbidity and mortality, and discussing measurement issues in terms of the lack of data and lack of comparative outcomes in studying disparities. A lot of my talk focuses on disparities in maternal care, but I think as we see from the coronavirus 2019 pandemic, and the fact that something like 23 states have not released racial or ethnic or other social determinants of health stratified data, that this is an issue in a lot of different areas. So with COVID-19, I think that it's more in the forefront and there's a lot of people speaking up about it. For disclosure information, I was the recipient of the Dean's Diversity and Healthcare Disparity Award 2 years ago, and I'm currently appointed to a 3-year term for the European Science Foundation College of Expert Reviewers, where I review their fellowship and their other research-associated applications. That is for an honorarium. I have no conflicts of interest in the board. Just want to start with some background information. This is from the popular press, the New York Times and PBS, speaking about the maternal morbidity and mortality crisis in the country that mostly impacts African American or Black mothers, whereas they have about 2 to 4 times increased rates of maternal mortality and also much higher rates of severe maternal morbidity. So many studies have identified higher rates of severe maternal morbidity in Black women as compared to white women. And these were in numerous populations throughout the country over periods of time from the 90s till today. Some studies show that the rates are twice as high in Black women compared to non-Hispanic white women. And severe maternal morbidity is 50 to 100 times more common than maternal death. So it speaks to the prevalence of this condition, and it has significant short and or long-term consequences. If you look at rates, in 1993, severe maternal morbidity was 28.6 per 10,000 deliveries. It's up to 35 per 10,000 in 2014. This equates to about 50,000 women in the United States in 2014 suffering from this. And it's important to recognize that many of these factors are external to the individual patient and the individual patient's comorbidities or past medical history. And they are dependent upon patient-level social determinants, so race, median income, occupation, education level, and also hospital level differences. These disparities are also present in obstetrical anesthesia, which has a place in my heart. And this has been described in the use of neuraxial labor analgesia, where minority women receive less neuraxial, so less epidurals, than non-minority white women. And minority women are also more likely to have a general anesthetic for cesarean delivery versus non-minority white women. And this has a slew of consequences and outcomes. This is just some of my research group's previous work on obstetrical disparities. And this is a visual abstract that we presented at the Society of Obstetrical Anesthesia as one of their best of research presentations. And my next slides, I actually break up these the tri-panel into separate slides. This is just to give more background. So in this study, we looked at a population of 6.9 million parturients from the states of California, Florida, Kentucky, Maryland, and New York. And we looked at the incidence of complications by race ethnicity, and Black women were more likely to experience complications than white women. And this included any complication, a stillborn baby, blood transfusion, a length of stay of greater than 7 days, placental abruption. So then we said, what can we do to reduce disparities? One of the major things that was highlighted in the Institute of Medicine's 2002 Unequal Treatment Report, which really kind of put disparities on the map and refocused a lot of people's attention and energies towards addressing disparities 17 years ago, is education. A lot of providers feel like they went into medicine to provide good for people, and it's very hard for providers to accept the fact that some of their care is unequal and that they may have implicit biases or other internal drives that are causing not the best care to be delivered to patients. Training, we recently this year, as part of the obstetrical division, had implicit bias training so that everyone's aware of their biases to address it. And for hospitals, a big proponent of the use of enhanced recovery after surgery programs. These are standardized delivery care protocols that use the best evidence, are evidence-based, and I think standardization helps to decrease implicit bias and make sure all patients are cared for systematically. We submitted this article to the Journal of Clinical Anesthesia, and it was accepted. And this is a slide, I hope it shows up big enough for people to read, that showed that Black patients, as compared to white patients, if you look at it by other social determinant strata, such as primary insurance payer, or medium income, or a hospital safety net burden, or the type of hospital that a patient goes to, or geographical area, or delivery volume, unfortunately, Black patients as compared to white patients, worse outcomes in all of these individual strata, which kind of teases at the fact that this isn't an issue with income, but it's an issue with race. And this comes up later in my talk when I mention the importance of including other social determinants in your research to help to reduce bias or confounding. So this sort of frames the work that even if you're a rich Black woman, you can have worse outcomes than a white poor woman. So it really shows the racial aspect. And I think that this was highlighted by the Serena Williams story that was in the newspapers, a very famous celebrity athlete. And even she reports that she had negative outcomes and felt that she wasn't maybe getting the best care. So the first thing I want to get into in terms of the methodological issues is when you look at disparities research, maybe even all types of research, it's always good to look at both the absolute and the relative disparities, or the absolute and relative differences, to have an idea of what you're actually studying and what the outcomes you're investigating are. So in the US, most research has both absolute and relative values. It's important to consider both when you're trying to reduce or eliminate health disparities. And my next slide shows you why. Because absolute measures are useful when the purpose is to assess progress towards reduction of a disparity, whereas relative is when you want to evaluate whether a disparity is actually being eliminated. Let me get into that with the next slide after this. So these two measures are different in scale, but also temporal changes could impact whether they decrease or increase. So the trends for both absolute disparity and relative disparity could move in absolute directions, even when you're looking at them both simultaneously. For example, the magnitude of absolute and relative Black-white disparities in infant mortality rates, how they changed over the 20th century. And that's this slide here. Image A is showing that from 1950 to 1990, there was a decrease in both infant mortality for Black, which is the blue line, and white infants. Whites are the checkered red line. And slide B shows you that absolute disparity decreased while relative disparity increased. So while the rates of infant mortality were decreasing for both groups, if you only looked at the relative disparity, you would have a very different picture or outcome or conclusion than if you looked at the absolute disparity, which is the red line in picture B. And that kind of tells you why you need to have both measures. The mathematics behind it is a little much to get into now, but I think this slide kind of highlights it. And this kind of gives some background text. So it has been shown that absolute disparities tend to be low when the overall rates of the outcome measure are high or low, and tend to be high when the rates are intermediate. Relative disparities are different. This is just to be aware of that issue when you're comparing research outcomes for papers over time. The next thing I would like to talk about are the actual data limitations in terms of the racial data that's available. So without having accurate data, it's a challenge to identify the disparities and to identify whether disparities are being addressed or unfortunately getting worse. However, everyone's under budget constraints. So you have to find solutions that increase the budget the least or are workarounds. And this should most likely include collaboration amongst private and public stakeholders. This is the Office of Budget Management's recommended variables for standardized collection of race, ethnicity, and language needed. So race is broken up into categories such as Black or African American, white, Asian, American Indian or Alaska Native, Native Hawaiian, or some other race. And there's some issues with granularity with the way that race is divided up, that I'll get to next. So there's 5 racial classifications, and this was established in 1997. However, in 2006, the Healthy People 2010 mid-course review showed that using these 5 categories, it's hard to produce statistically reliable estimates for most of the quality and access measures for the Native Hawaiian populations and for the American Indian populations. And also for anybody that reports more than one race personally. So it tells you that even with these 5 categories established in 1997, it's still hard to aggregate data. So the fact that these are 5 large groups means that by necessity, you're omitting some groups. And this could mask substantial variation in health within some of the groups. For instance, Latin Americans from Mexico are different from Latin Americans from Argentina, or different from Puerto Ricans, or different from Ecuadorians. And same thing for members of the Asian community. People that are of Chinese descent are different from people from Japanese descent, or different from people of Filipino descent. But unfortunately, a lot of these studies group everybody as either Hispanic or Asian, and causes false study reference groups because of that. The other issue when you look at data from the United States is that health status of immigrants is different amongst generations of immigrants. First generation versus second generation versus third generation. And in a lot of research, this shows up as the so-called quote-unquote Hispanic paradox, whereas some members of the Hispanic community have better outcomes than white Americans. And it's believed that a lot of this has to do with selection of who immigrates here and what generation of immigrant the person belongs to. I think that there's not really any clear answers for that. This is just information on persons that report multiple races. As I mentioned, that if somebody reports multiple races, it kind of makes the research on them a little bit harder and more difficult. There seems to be issues with it. So this just gives you an idea. And this also shows you the percentage distribution of people who report multiple races. So the main problems with the racial data is how race and ethnicity is identified. Is it self-report, or is it an intake clerk or intake nurse determining someone's race, inadequate sample sizes, and missing data? The other big issue is that some data sets include racial data, but do not have information on education, occupation, median income, which, as that slide that I showed you of the maternal outcome stratified by different social determinants, how that plays a role or why that's of importance. This is especially seen in state and local analyses. The national data seems to be a little bit better. So the modes of data collection are usually self-report from patients, which is the preferred method of collecting racial and ethnic data, is that of the patient self-report, and observation. And observation, I think, is fraught with a lot of mistakes because you have somebody making assumptions about someone's race just on their skin color. So people that report more than one race, this obviously has an impact, and or people whose skin color doesn't adequately reflect their racial upbringing. So self-report is how people view themselves and the population groups with which they identify. And like I mentioned, this is the preferred approach. Unfortunately, information in medical records and administrative data sets comes from a combination of self-report and observation, which makes some of the data unreliable. And observations may differ from how people would self-identify. This is important for Hispanics, American Indians, and people of more than one race. This can lead to biased data, biased results, biased conclusions. Inadequate sample sizes are another major issue, especially for some racial populations that are smaller or are part of the majority or the minority majority. And when you have inadequate numbers, you cannot produce reliable samples, reliable estimates. Analysis of subgroups of major populations, like I mentioned earlier, Hispanics and Asians from different countries, to lead to inconclusive or misleading results. Missing data, basically medical records, administrative data sets are missing a lot of data. And in 2005, there was a study that looked at automated data, and it showed that almost 1/3 of discharges lacked racial information, and 1/2 of discharges lacked information on ethnicity, which gives you an idea of the magnitude of the problem. Lack of information on contributing factors. This is what I was talking about, where studies do not include information on education or occupation or income. It's important to include these variables because they could have independent and also interactive effects on the racial data, either effect modification or confounding. And it's hard to get accurate estimates when you go into something knowing that you have a lot of unmeasured confounders and known unknowns. So administrative records are less likely than population-based surveys to contain information on SES, language, or occupation. Notable exceptions are Hawaii and California, which do their own data collection. They seem to have some of the better data sets nationally. Unfortunately, a lot of the state or other collection agencies do not have compatible data sets. So the lack of standardization impedes comparisons of disparities across states and localities. Strategies to address this would be the states working with the federal government to come up with a standardized approach so that everybody collects the same data and so that everything is comparative across groups. For the sample sizes that are of inadequate size, just increasing the overall sample size. Bigger samples will allow for more studies to be done, and maybe even doing oversampling of some regional ethnic minority groups so that their numbers are increased. This can include periodic targeted surveys, polling of data over multiple years, linking data sets is another possible solution to create a single richer database. You take a data set that has race and ethnicity data, and you take a data set that has education, social economic status, and occupation, and you have a much better solo data set than a single data set. The other way that this is being addressed is through indirect estimation and modeling, using Bayes' theorem and geocoding to fill in gaps in the data collected. So geocoding facilitates the identification of socioeconomic health, healthcare disparities, and is very helpful at the local level when you're looking at communities or neighborhoods. This is more about indirect estimation and showing how this could fill in the gaps of the data set. And it's a relatively cheap, let's say, approach, because you just need a computer with memory, and you could create estimates based off that. This is just more information about indirect estimations and modeling aspects, basically what I said. Just showing that preliminary studies show that indirect estimation does improve the reliability of estimates, and so does pooling data. But the issue with pooling data is if there's an underlying trend, the trend effect will show up in the data. So you have to really make sure that there's no underlying trend that you're trying to investigate or look for, because then your data is going to be influenced by that. This is the importance to include other measures of socioeconomic status in your data sets, because without it, your estimates are often biased, they're often incomplete, or they're often done in inconsistent manners. So characteristics such as minority of racial ethnic status, low socioeconomic position, and rural residents frequently coexist within populations. This is, I guess, now known as intersectionality, and this reflects both exposures and vulnerabilities that may interact to produce disparities. And for those that aren't aware with the term intersectionality, it's how that someone could be, you would describe me, white, male, Jewish, doctor, and it's all of the characteristics that somebody has and how they overlap with Venn diagrams and play into one another. So education and income are non-randomly distributed across racial and ethnic groups. If you look at the lower categories of socioeconomic status, African Americans and Hispanics are overrepresented. Some people feel like if you control for income, then the difference between blacks and whites disappears, that it's an income effect. But actually, studies show that the difference between racial groups remains even if you control for income. And I think that slide I included earlier on the maternal outcomes that showed that Black women in every strata of socioeconomic class had worse outcomes. So it was across the board. This is just more information that it's fruitful to examine the effects of socioeconomic status within the racial and ethnic groups to try to tease out the intersectionality and any effect modifiers, and to try to come up with coefficients for the impact that each factor has on a person's outcome. This is talking about how the Institute of Medicine wants to standardize collection of race and ethnicity data, and that they want to have more fine-grained categories of ethnicity to try to tease out the differences between the Hispanic broad group, so that people could put individual responses for that. More discrete population data is needed to identify opportunities for quality improvement and outreach without inefficiently targeted interventions to an entire broad race or Hispanic ethnicity category. It speaks to the fact that all Hispanics are not the same. You know, you really have to look at the country of origin, and there may be factors that impact one country's origins versus another. Opportunities should be afforded for individuals who want to self-identify their ethnicity or language when it's not specifically listed, and this talks about the problems with observational data and when data is collected as just observations. So the presence of data on race, ethnicity, and language does not, in and of itself, guarantee subsequent actions in terms of analysis, quality of care data, to identify disparities or actions to reduce or eliminate disparities that are found. So just because we have the data available doesn't mean that the studies are going to be done. However, the absence of data essentially guarantees that none of the studies will occur and none of the actions needed to address disparities could be partaken or could be implemented. So it really speaks to the importance of data and then acting on data, come up with solutions. Thank you. This was a difficult form with the Zoom presentation and the PowerPoint slides. I'm happy to focus in on any slides that I may have talked through and to answer any questions that people have. Thank you for your time. Thank you.
Thank you, Dr. White. This is Christopher Gonzalez. Sorry, I actually had a question. I think it was slide 13 when you showed us the outcomes. I think it was number 13. Sorry, but I was just curious as to what is the there you go. What is the outcome here?
Sure. Sorry about that. The outcome here is severe maternal morbidity, which is 21 different factors listed by the CDC of maternal care in the postpartum period, including use of blood transfusion. I kind of had a freeze right now, but it's basically 21 outcomes, negative outcomes that are categorized as severe maternal morbidity by the CDC definition. This is showing that each of these dots is a Black Victorian compared to a white Victorian, that even if you stratified by insurance status, the Black patients did worse than white patients. Even if you stratified by hospital visited, same story. Rural versus urban, same story. And median income, same story. And this kind of addresses people that feel like racial differences between Black and whites is really just an income story. Yeah, Blacks are more likely to be poor, whites are more likely to be rich. So of course there's differences between the races because their incomes are different. This shows you that for every income strata, Blacks still did worse than the white patients.
And then do you have any, I guess, additional insight into how the Hispanic cohort compares to this?
In terms of maternal morbidity and mortality, I feel, I don't have the data in front of me, but my recollection of the data when we wrote it up and analyzed it was that Hispanics were not statistically significantly different than the white patients.
Hi, this is Martin Shapiro. Can you hear me?
Yes.
Yes. I'm sorry I was a little late. I had trouble linking to the Zoom, but it was a very interesting presentation. I was wondering, in terms of these measures, I mean, sometimes there are studies that suggest that differences reflect the site of care. Have there been analyses of these this set of issues that look at the extent to which the venue of care is a contributing factor and explains some of the differences between groups.
Yes, specifically for maternal outcomes, I believe that Dr. Howell from Mount Sinai has been in the forefront of looking at Black majority serving hospitals and their impact on outcomes for both Black and white patients, showing that if you're a patient at one of these Black majority hospitals, you do worse than if you're a patient at a white majority hospital. And I believe TSAI has also looked at the site of care after 3 surgeries and showed basically if you have surgery at a safety net burden hospital that is high safety net burden, so high percentage of Medicaid or uninsured, you have worse outcomes. So 2 things. Yes, site of care does matter. In terms of our study findings here, we found that Black patients as compared to white patients did worse, whether it was at a low, medium, or high safety net burden hospital. So the Black patients still did worse regardless of designation. And same thing with hospital delivery and rural status. We are working right now on a follow-up paper using interaction or effect modifier terms between these hospital level variables and the patient level variables of race and the insurance status, medium income. And we did find that Black women who have who deliver at either a high safety net burden hospital or at a majority Black servant hospital did do worse. So there was a significant interaction effect than the white women at those hospitals and the white women at the majority white hospital. So it's both a site of care issue, so an inter-hospital issue, but it's also an intra-hospital issue. It seems like the data shows that it's both. That you can't just say, oh, because they're going to worse hospitals, they're having worse outcomes. They're going to worse hospitals, having worse outcomes, and they're doing worse than the other patients at those hospitals. At least our data is showing, and from other groups also.
Has Martin again? Has anyone? Can you hear me?
I can hear you. Yes.
Yes. Has anyone looked at the processes of care to understand to what extent the processes of care are explaining the differences in the rates of these events?
I believe that Howell has looked at this, and one of her papers actually comes up with maternal bundles to address these differences in care. I think some of it has to do with hospitals that have enacted enhanced recovery protocols or their perioperative services. We recently published something on safety net burden hospitals and anesthesia care for hip surgery, and we found that most high safety net burden hospitals do not have perioperative services or separated pain management services or separated regional anesthesia services versus the low safety net burden hospitals. So it seems like there are critical differences in terms of their perioperative staff and preparation. And I believe that there are also differences in terms of some of their other processes, in terms of like the intake nurses, preoperative medications, preoperative nutrition, adherence to guidelines is shown between these different hospital groups.
I believe that there's some international evidence that maternal mortality is higher in the US than in other advanced industrialized countries. Has anyone looked in those countries at whether there are, for example, socioeconomic disparities or racial ethnic disparities, which are obviously harder to look at in some countries, in care, or what factors might explain why these such differences occur, and to what extent do they extend to these other complications short of death?
Not off the top of my head could I name international studies. It is true that the U.S. has the highest mortality rate, and when you tease it out by race, there's a stark difference between the Black and white mortality rates. But I can't name something off the top of my head about racial or ethnic differences. Fortunately, I think the U.S. is #1 in having presence of these disparities, and you know, the publications, of course, follow that in terms of tracking it. But unfortunately, I think we're seeing a much different story than the rest of the Western world in terms of our outcomes. And part of it, I believe, is because of the you know, our racial history and everything.
Mm-hmm.
Does anybody have any additional questions? Well, I want to thank Robert for a really informative and disturbing set of analyses, but I would love to see you continue this work, and we stand ready to help you in any way that we can from the Center for Health Equity, and want to applaud you for moving this work forward. Thank you very much.
Thank you. I appreciate that. Thank you.
All righty. Take care.
Bye, everybody. Thank you.
Thank
Bye-bye.
you.